Hello and welcome back. Today, we're discussing acute appendicitis, a common cause for emergency abdominal surgery. Appendicitis is the inflammation of the appendix, a small pouch projecting from your large intestine. The inflammation is acute, meaning it comes on suddenly. It's a medical emergency. If untreated, the appendix can rupture, leading to life-threatening infections. The most common cause is a blockage in the appendix lining, often by a fecalith. This obstruction traps bacteria and mucus, leading to increased pressure, inflammation, and infection. The pressure cuts off blood supply, causing tissue death and increasing the risk of rupture. Understanding this process highlights why appendicitis requires urgent clinical attention. Appendicitis is incredibly common. It is the most frequent cause of acute abdominal pain that requires surgery. The lifetime risk is around 7 to 8%. This isn't a rare disease. It's a diagnosis you will encounter regularly. Appendicitis is known as a great mimicker, and its symptoms can overlap with other conditions. A delay in diagnosis can have devastating consequences. If missed, the inflamed appendix can perforate, leading to peritonitis and sepsis, which can cause organ failure and death. Our ability to recognize and manage appendicitis directly impacts patient safety and outcomes. This lecture is structured to give you a clear, stepwise plan from start to finish. We'll explore the epidemiology and pathophysiology, who gets appendicitis and the sequence of events that happen inside the appendix. Then, we will move into the core clinical aspects, including typical and atypical presentations in children, the elderly, and pregnant patients. We will tackle diagnosis, including scoring systems, lab tests, and imaging. Finally, we will cover management and potential complications. We will conclude with key takeaways, so let's get started. Let's discuss the epidemiology of acute appendicitis. Understanding who gets it helps us form our initial clinical suspicion. Appendicitis is common, but doesn't affect everyone equally. There are patterns related to age and sex. Peak incidence is in adolescents and young adults, ages 10 to 30. So, appendicitis should be high on your list for a teenager with right lower quadrant pain. It can happen at any age, but is rare in infants. There's a slight male predominance, about 1.4 times more likely. Incidence is higher in industrialized countries versus developing nations. This may be due to diet and lifestyle. Despite a possible decline, it remains a major reason for emergency surgery. Let's explore the risk factors for appendicitis. One theory revolves around diet. A diet low in fiber is considered a risk factor, potentially leading to fecaliths obstructing the appendiceal opening. Another area of research links appendicitis to hygiene, the hygiene hypothesis. Less exposure to microbes in childhood might alter immune system development. Finally, family history increases risk. Individuals with a first-degree relative who had appendicitis are at higher risk, suggesting a genetic component. Let's break down what actually triggers appendicitis inside the body. It all starts with obstruction of the appendiceal lumen. Think of it as a cork in a bottle. The most common cause is a fecalith, a hard mass of stool. But in kids, swollen lymphoid tissue after infection is often to blame. Less commonly, tumors, parasites, or even food particles can block the appendix. Once blocked, mucus and bacteria build up, pressure rises, and the stage is set for inflammation. This is the fuse: obstruction, pressure, and bacterial overgrowth, ready to ignite appendicitis. With the appendix blocked, pressure builds and blood flow is cut off. This causes swelling, ischemia, and that classic vague belly pain. As inflammation worsens, bacteria invade the dying wall, and pain shifts to the right lower abdomen. If untreated, the wall dies, weakens, and can rupture, spilling pus and bacteria into the abdomen. This leads to peritonitis, a life-threatening infection. Sometimes the body walls off the leak, but often infection spreads rapidly. The whole process can unfold in just 24 to 48 hours. Speed is critical. So how does appendicitis actually feel? It usually starts with vague pain near the belly button, then migrates to the right lower abdomen as inflammation spreads. Loss of appetite is almost universal. If they're hungry, think twice. Nausea and vomiting follow the pain, not the other way around. Low-grade fever develops as things worsen. The classic story: anorexia, periumbilical pain, migration to the right lower quadrant, then nausea, vomiting, and fever. Timing and sequence matter. Listen for this pattern. Now let's examine the patient. They'll often lie still, knees up, to avoid jostling the inflamed area. Palpate gently, saving the right lower quadrant for last. Look for tenderness at McBurney's point. Guarding and rebound tenderness signal peritoneal irritation. Special signs: Rovsing's, pain in RLQ when pressing LLQ, psoas, pain with right hip flexion, and obturator, pain with internal hip rotation. A retrocecal appendix may cause less obvious signs. Watch for back or flank pain. Combine these findings to build your clinical case before ordering tests. Not every patient presents classically. Young children may just be irritable or lethargic, with vague pain and vomiting. Perforation risk is higher. Elderly patients often have subtle symptoms: less pain, little fever, sometimes just confusion. In pregnancy, the appendix shifts position, so pain may be higher up, and symptoms overlap with normal pregnancy. Atypical appendix locations can cause urinary or rectal symptoms. Don't be fooled by diarrhea or dysuria. Always keep appendicitis in mind with unexplained abdominal pain, especially in high-risk groups. A thorough history and exam are your best tools to avoid missing these tricky cases. Clinical scoring systems combine elements of history, exam, and labs to generate a score. This helps stratify patients into low, intermediate, or high-risk categories for appendicitis, adding objectivity to clinical judgment. The Alvarado score is a 10-point scale assigning points for symptoms, signs, and lab findings. Points are given for right lower quadrant pain, anorexia, nausea, vomiting, tenderness, rebound tenderness, fever, and elevated white blood cell count. A low score suggests appendicitis is unlikely. A high score makes it very likely. Intermediate scores benefit most from imaging to confirm the diagnosis. Understand how to use scores as a structured tool to support your clinical decision-making. After clinical assessment, we use objective data from labs and imaging to solidify the diagnosis. The most important blood test is the complete blood count, or CBC. We look at the white blood cell count. In most cases, you will see a mild to moderate elevation. Another helpful test is the C-reactive protein, or CRP, a general marker of inflammation. Normal CRP and white blood cell count make appendicitis less likely. Also check a urinalysis and, in women of childbearing age, a pregnancy test. When the diagnosis is still uncertain, imaging is key. In children and pregnant women, ultrasound is preferred. For other adults, Connecticut scan is the gold standard. CT scans are very accurate for diagnosing appendicitis and identifying other causes of pain. The main drawback is radiation exposure. Diagnosing appendicitis can be a minefield of potential errors. In young women, consider gynecological issues like ovarian torsion or pelvic inflammatory disease. Another pitfall is gastroenteritis, especially in children, with nausea, vomiting, and cramping. Appendicitis pain usually precedes vomiting and localizes, unlike the diffuse pain of gastroenteritis. Anatomical variations can also mislead. Trust the patient's story, even with atypical pain. An appendix pointing upwards may mimic cholecystitis. Be aware of confirmation bias, which can cause you to ignore signs pointing to a different diagnosis. Maintain a broad differential diagnosis, systematically considering all possibilities. Be a good detective, following clues wherever they lead. Let's discuss the step-by-step management of a patient with suspected appendicitis. Imagine your patient has just arrived in the emergency department. Appendicitis is suspected. Immediate priorities are stabilization and preparation. First, establish intravenous access. Administer IV fluids like normal saline to correct dehydration. Address pain and nausea with IV opioids and antiemetics. Make the patient NPO in preparation for potential surgery. Order lab work, including a CBC, CRP, and a pregnancy test. Consult surgical colleagues early. Once uncomplicated acute appendicitis is confirmed, the standard treatment is surgery, an appendectomy. Explain this to the patient, obtain consent, and prepare them for surgery. Preoperative antibiotics reduce the risk of wound infections. Surgically, appendectomies can be laparoscopic or open. Laparoscopic approaches are common, involving small incisions and specialized instruments. Benefits include less pain and quicker recovery. Open appendectomies involve a larger incision. This approach might be preferred if the appendix has ruptured. The goal is always the safe removal of the appendix. Non-operative management with antibiotics is an option for uncomplicated cases. However, appendicitis can recur. The decision requires a well-informed patient. The management of the patient does not end when they leave the operating room. Post-operative care is just as important to ensure a smooth and complication-free recovery. For a patient who had a laparoscopic appendectomy for simple, non-perforated appendicitis, the recovery is usually very quick. They will often be able to start drinking clear liquids a few hours after the surgery and advance to a regular diet as they tolerate it. Their pain is typically well controlled with oral pain medications, and they are encouraged to get out of bed and walk around as soon as possible to prevent blood clots and help their bowels wake up. Most patients who undergo a routine laparoscopic appendectomy can be discharged from the hospital within 24 hours. Some centers are even performing these as same-day outpatient procedures. Before they go home, we provide them with clear instructions about wound care, activity restrictions, and signs of potential complications to watch for. We advise them to avoid heavy lifting or strenuous activity for a week or two, but encourage gentle walking. They should be told to call their doctor or return to the hospital if they develop a high fever, worsening abdominal pain, redness or pus from their incisions, or persistent vomiting. The post-operative course is different for patients who had a perforated or gangrenous appendix. These cases are more complicated. These patients will often need to stay in the hospital for several days to receive a longer course of intravenous antibiotics to treat the more severe infection. They may also have a surgical drain left in place to help remove any infected fluid from the abdomen. Their return to a normal diet may be slower, as the widespread inflammation can cause the bowels to become sluggish, a condition called a post-operative ileus. Their pain management might be more intensive, and their recovery will generally take longer. Before any patient is discharged, we schedule a follow-up appointment, usually with the surgeon, for about 1 to 2 weeks after the operation. This visit is to check on their recovery, inspect the incision sites to make sure they are healing well, and answer any questions the patient might have. For older patients, particularly those over the age of 40 or 50, it is also crucial to review the final pathology report from the removed appendix. This is to ensure that the appendicitis was not caused by an underlying tumor, such as a carcinoid tumor or adenocarcinoma, which would require further investigation and long-term follow-up. This final check completes the circle of care for the patient. While most appendicitis cases are straightforward, complications like perforation can arise. Perforation or rupture is a significant complication where pus and bacteria spill into the abdominal cavity, causing a severe infection. The body may try to contain the spillage, leading to a phlegmon or an abscess. A phlegmon is an inflamed mass, while an abscess is a well-defined pus collection. Management differs from simple appendicitis. A large abscess might first require percutaneous drainage, followed by intravenous antibiotics. After recovery, an interval appendectomy is typically scheduled. This planned surgery removes the appendix to prevent recurrence. This staged approach reduces surgical risks. After treatment for acute appendicitis, especially a complicated case, there are still some long-term considerations. One is recurrent appendicitis in patients treated non-operatively with antibiotics. The recurrence rate can be high. Another involves the pathology report. In some cases, the cause is a tumor, most commonly a neuroendocrine tumor. Larger tumors may require a right hemicolectomy. Consulting the surgery team is critical in managing suspected appendicitis. Long-term follow-up is essential, particularly for complicated appendicitis or unexpected pathology. For appendiceal tumors, follow-up will be guided by an oncologist. All right, team, we've covered a lot today, walking through the clinical pathway of acute appendicitis. Let's recap the key points. Appendicitis is a common surgical problem, affecting nearly 1 in 13 people. It's a diagnostic challenge. Delayed diagnosis can lead to perforation and peritonitis, increasing patient risk. Pathophysiology begins with appendiceal obstruction, causing increased pressure, ischemia, and potential rupture. Recognize the classic presentation. periumbilical pain migrating to the right lower quadrant, anorexia, nausea, and fever. Diagnose with physical exams, scoring systems, lab tests, and imaging. Manage with IV access, fluids, pain control, and NPO status. Appendectomy is the definitive treatment. Ensure proper post-operative care for complete recovery. As we conclude this lecture, I want to leave you with a few final thoughts and clinical pearls that will serve you well in your careers. The single most important factor in achieving a good outcome is timely recognition and management. Time is tissue. The longer the inflammation goes on, the higher the risk of rupture and life-threatening complications. Your role as the first-line clinician, whether in an emergency room, an urgent care clinic, or a family practice office, is to have a high index of suspicion. Never dismiss abdominal pain, especially in a young person, without carefully considering appendicitis in your differential diagnosis. Here is a key clinical pearl. Trust the patient's story, especially the evolution of their symptoms. The migration of pain from the periumbilical area to the right lower quadrant is a powerful piece of evidence. While physical exam signs and lab tests are important, the history is often the most revealing part of the evaluation. Another pearl is to never forget the atypical presentations. Remember that the elderly, young children, and pregnant patients often don't follow the textbook. In these groups, you must be even more vigilant and have a lower threshold for ordering imaging. Their atypical symptoms are a setup for a misdiagnosis if you are not careful. Always remember that diagnosing appendicitis is a team sport. Your job is to recognize the possibility, stabilize the patient, and initiate the workup. But you must consult your surgical colleagues early. They are the experts in the definitive management, and their input is crucial in making decisions. Clear and respectful communication between the emergency department, the surgical team, and the radiology department is the backbone of excellent patient care. You are a vital part of that team, and your sharp clinical skills set the entire process in motion. Ultimately, managing appendicitis is a perfect example of what it means to be a good clinician. It requires you to integrate knowledge with keen history-taking and physical exam skills. It tests your ability to make decisions under pressure, to use diagnostic tools wisely, and to work effectively with others. It's a condition you will see again and again, and each time you do, you will have the opportunity to make a real difference in someone's life, turning a potentially dangerous situation into a routine recovery. Keep studying, stay vigilant, and never stop learning. Thank you for your attention.